Thank you all for joining us for this lunch session.
As the slides come up, I do not want to be remiss in thanking Hologic and Medtronic because they very, very kindly supported this lunch. So please make sure to thank them for their support of our meeting because we cannot have these meetings without them. So please make sure to thank them individually.
Alrighty, so we're going to talk about thyroidectomy. How do y'all do it? So earlier this spring, we had a research survey that was approved by the AES Research Committee, and we sent it out to members asking you to answer questions about how you do your thyroidectomies. We got these survey results back, and here we are today sharing them with you in aggregate. We asked you about what type of practice you were in and how long you've been practicing. The majority of our respondents have been in practice greater than 15 years and are in academic practices. The number of thyroid surgeries performed annually varied across the group, with some performing between 0 and 50 and others performing greater than 150. We then asked what was your most common use of performing hemostasis, and the majority of respondents said that they used an energy device. When looking at what energy devices surgeons used, the most common was the ligature. We then also asked why you chose the energy device that you did, and the majority of respondents said that they thought it would decrease their operative time, with the second most common concern being the degree of thermal spread. We also asked you how often do you use a hemostatic agent, and the majority of respondents said that they did all of the time. Following this, the most commonly used hemostatic agent was oxidized cellulose, most commonly known as Surgicel. We asked you what drives the decision to use a hemostatic agent, and the majority of our respondents actually answered other. So this is something that we are going to be interested in hearing more about, that it wasn't about perceived intraoperative blood loss, the disease pathology of the case, or patients on preoperative anticoagulation. We then asked how often you use a nerve monitor, and the majority of respondents said that they use a nerve monitor for all of their cases. The majority of respondents then said that they used a nerve monitor that had audible feedback only and didn't have a nerve monitor tech in their operating room. Lastly, we asked about autofluorescence, and the majority of surgeons don't use autofluorescence when performing thyroidectomy, although a small subset has been beginning to use it in a portion of their cases. Thank you for your time and listening to the results. If you haven't completed the survey, there is a QR code that's on the screen if you're interested in filling it out for us. And now I'll turn it back over so we can hear about how our panelists do their thyroidectomies.
Thank you so much for giving us those results. But I do, because it's a small population of the AES membership, if you can consider doing that survey, it would be nice to get a better idea of how folks do it really. Next, I'd like to introduce Dr. Richard Hoden, who's the Warsaw Family Professor of Surgery at the Mass General Brigham and Harvard Medical School. He's the surgical director of the MGH Endocrine Tumor Program and vice chair of faculty affairs. He is going to tell us how he does it.
Thank you. That was really interesting to see those survey results. I know that, was there, how do I do the slides? Is it the green button?
Green.
Okay. I kind of knew already I was a dinosaur, but now with those survey results, it is absolutely confirmed. So I'm glad I'm going first and I can sort of set the stage on how I do it, which is a no-frills thyroidectomy, and realizing that basically nobody in this room will do it the way I do it, and I understand that. My fellows have been telling me that for many, many years, so I won't take it personally. So I have a approach that I would say is quick, safe, and cheap. And it uses two things. I use clips, and I use the cautery, and that's it. Clips I use on the stain inside, usually 2 clips on the vessels or tissue, and then I just cauterize the thyroid. I never use a tie. I can't even imagine the last time I used a tie. I haven't used a stitch in probably 30 years in a thyroid. I do not use any of the energy devices. I never pick up a scissors. And I don't use the nerve monitor either, which I'm not going to get into. We won't even start that conversation. But I would say I rarely use it. I do use the nerve monitor on very select cases, but not sort of the typical thyroid. And I'll just I have a pretty brief presentation overall, so I'll just say that I think most people, before the case, like in the holding area or something with the patient sitting up, I'll mark the neck, find a nice crease. I think most people do that. And always mark the sternal notch, because that can things can be distorted when patients are asleep under anesthesia with the endotracheal tube in. And my basic steps for doing a thyroidectomy after incision and exposure, I won't go through that, but basically I essentially always take down the superior pole first, and again using clips and cautery, and then sort of come around the top, being very careful to look out for the superior parathyroid and also the blood supply to the superior parathyroid. Make sure I sort of hug the thyroid around the top, and then make a big point of the tubercle of Zuckerkandl. In my mind, that's like the key structure during the operation, because if you hug that tubercle and medialize it, and you look in that groove, that's where the nerve is almost all the time. I mean, obviously there's going to be some variation in terms of anatomy, but it's, I think, the most reliable place to find the nerve, the most reliable way. It's the quickest way, and it facilitates the rest of the operation, because once you find the nerve, you can sort of keep that safe and then continue the operation from there. I do a very careful capsular dissection. And again, this is for like sort of typical thyroid. We're not talking about somebody with extensive nodal disease or a big mediastinal goiter type of a case. But anyway, do a capsular dissection, again using clips and cautery, and then making my way sort of inferiorly up to what I call the adherent zone, where the nerve enters. And in there, obviously, sometimes there's a little bit of thyroid tissue that's difficult to remove and is not sort of necessary for a typical like near total thyroidectomy. And I do use cautery on that tissue. It drives some of the fellows and residents crazy, but I can tell you it's safe if you're careful, and I use kind of like intermittent cooling by just irrigating periodically so the tissue doesn't get too hot. And I'm going to end there with my simple, cheap thyroidectomy.
Thank you so much. Next, we have Dr. Jennifer Kuo. She is the Director of Interventional Endocrinology Program at Columbia University. She is also the Program Director of Endocrine Surgery Fellowship Program, Director of Endocrine Surgery Research Program, and the Vice Chair for Informatics for the Department of Surgery. We're going to hear about how she does it.
All right. Good afternoon, everyone. So in full disclosure, yes, I still operate on the thyroid gland. I am a consultant non-relevant to Medtronic and Histosonics, and I may have misinterpreted the assignment today, so which will become obviously clear. But the thyroidectomy, I am a James Lee trainee as well, so we actually, one of the big things for us is we all have a butterfly on-point ultrasound that we use in the operating room. And we find it extremely helpful because it helps to confirm the pathology, especially if you haven't seen the patient in 3 months or so. It helps. We've occasionally found a new lateral neck lymph node that has popped up in cancer cases in the interim, and we can biopsy it. We also use it to really evaluate the thyroid gland in the lobe, and we still pick a crease line, a natural crease line on the patient that to place the incision. But we found that you want to find an incision that gives you access to the superior pole. more so than the lower pull, because the superior pull is really hard to pull down, whereas the lower pull you can more easily pull up. And so our incisions actually ride pretty high, and you want to make sure that incision actually is pretty flexible across the neck. And that allows us to make our incisions pretty small. I think most of our incisions are actually 3 centimeters in length for a standard thyroid gland, and very rarely do we go above 6 centimeters for large nodules. So huge advocate of ultrasound in general, but the butterfly is very helpful for that point of care assessment in the operating room. Some of the unique things that we do with our thyroid technique, we use a spring retractor. It actually has to be springy, and that allows us to, again, actually move the incision all over the neck. We use the James Lee Army-Navy technique as our third hand, so larger side goes in your pants. You got to make sure your pants are tied very tight, and you get a little yoga movement because you use your waist to help retract and open up the space. We also, a big part of our operations is going to be ligature. That is our preferred energy device. Ligature, for those of you guys who don't know, is an electrical surgical device that is permanently used to seal and divide blood vessels and tissue bundles up to actually 7 millimeters in diameter. It uses a combination of radiofrequency ablation and mechanical pressure to fuse the vessels and seal them. And there's various ligature devices that we've used before. So we started with the small jaw, which is a little bit blunt tip, but that was their index version of the device. And it's fine. Occasionally we still get them in our trays, and you can use them. But with our small incisions, actually, it's a little sometimes harder to visualize with the bigger tip. And so about 10 years ago, they came out with the Ligature Exact Dissector. And this you can see is a much finer tip. It's a little bit longer, and it allows for more precise dissection. And I include the laparoscopic ligature here because some of us do transoral thyroidectomy. And so you can, our preference between the blunt tip versus the Maryland jaw is the Maryland jaw tip, which is their newer version of this. So a lot of these devices now have hand switching, which allows you to control everything from the hand device. But most of us at Columbia or Columbia trained still prefer using the foot pedal as an option. All of these have non-stick nanocoating now that allows for minimal eschar buildup, although it still can. And there's an integrated cutting technique where you can seal and cut using the same device, allowing for greater efficiency. And the laparoscopic instruments allow rotating shafts, obviously. So there's the only study that I found comparing devices in thyroidectomy was actually published by one of our panelists back in 2011. They compared the original ligature to the original harmonic scalpel and found that there was really no difference in complication rates between the two, although the harmonic allowed for slightly better OR efficiency. But that was like comparing the original version. So this is a table that compares the new vessel sealing energy devices now with the current devices. And so you can see with the Ligature Exact, it's greater diameter vessels that you can more confidently ligate. It does have a faster cooling time now. Compared to the original version. The thermal spread was always a criticism of the ligature previous to the Ligature Exact, but now it's pretty minimal, and there's the different mechanisms. So, little tricks and technique using the ligature that I came up with is there is greater flexibility in terms of increasing the length of the sealed portion, and we do this often on vessels that you have a greater concern are going to bleed. I still actually suture ligate the superior pole on the stay side and use the ligature on the thyroid side. And then I'm very OCD in the OR, and I like the foot pedal activation, especially when working with fresh trainees. And then I pulled Columbia alumni on their pearls of wisdom. So beware that the thermal spread doesn't just apply to the lateral margins. It is also can occur anterior and posterior to your jaws, so you have to be cognizant of that, especially when working closer to the nerve. How many ligature points to perform a total thyroidectomy? Eric Quo has counted, and it's 24 with our technique. I love the foot pedal, one, because I like playing with the residents, and so does my colleague, Dr. McManus, who's now at MCW. It's very funny to figure out how long it takes for some residents to figure out they're actually not controlling the ligature, and some actually never realize that. And then from Wise James Lim at OHSU, remember to clean the crap from the crotch. So this is the eschar that builds up. It really builds up at the crotch of the jaw, and so for allowing a greater efficiency in terms of the cut, you want to make sure that that eschar buildup is cleaned pretty routinely through the case. We do always divide the isthmus. We divide flush to the contralateral lobe so that if we have to do a completion, we can actually not go through midline where there's the greatest scar buildup. I use a nerve monitor all the time. I still prefer the old-fashioned single-channel Nirvana system, which gives the greatest clarity, and it's not too hypersensitive. It also doesn't give us a lot of false positives. So we have 3 machines that are really trying to die on us, and we are really trying to keep them alive. But I have used the newer Nirvana multi-channel system as well as the NIMS multi-channel system, so we know how to use those if we do it. When we use the nerve monitor, we always use it to confirm. We don't use it to actually identify the nerve. And then lastly, we are huge proponents of Tisseel. There are certainly hemostatic benefits to it, but we actually use it more for seroma prevention for our patients, especially those that have thicker necks. So that's what I got for you.
Excellent. Thank you so much. Next, we have Dr. Nancy Perrier. She is the tenured Walter and Ruth Sterling Endowed Professor in the Department of Surgery, Surgical Oncology at MD Anderson. She's also the Director of Value and for the Division of Surgery, Section Chief, Medical Director, Assistant Dean. The list go on and on for these folks, but she doesn't need a lot of introduction to this crowd, but please welcome Nancy Perrier for how she does it.
Thank you, Mary Beth, and it's all perception, right, what the assignment was and what we perceived. So these are some traditional slides in that perception, but I really acknowledge that this is years of just input and iterations, lessons, because of the concept and the idea that the first draft just isn't good enough. Continue to improve and get better. So this is what has happened through the years. So this is the positioning that we use in the operating room that I use, a roll behind the shoulders, tucking the arm. Really important that the ET tube fall flush with the face so that we can prep in the chin. Like you, Rich, always using the sternum, I always want the chin in my field just to make sure I understand laterality. This is the positioning on the table, again, with the patient strapped at the body level and just seeing, I do these cases and I really traditionally do it the Mayo way, the traditional Mayo way, and then I was a fellow at UCSF and picked up some tips and trips from Arlo. So this is kind of a combo, but that 30-degree angle of the bed, particularly in women, just to allow gravity of chest tissue or breast tissue to fall flat. And I'm also pretty adamant about ensuring that I understand that angle because that's the angle of the nerve when I walk in the room and look and just knowing so that I'm consistent and knowing where it is. After the patient's hyperextended, again, looking at the neck with to discern where the incision should go. It's almost consistent that I'm always going to feel for the cricoid, a finger breadth below that. In my hands, it's usually about 2 finger breadths above the clavicular head, not the sternal notch. And the wording is it's a smirk, not a smile for the incision. And I'll measure the length of a 10-blade knife, come in by half, and then make it shorter than that. I'll show you those incisions. just really preoperatively having some idea of exactly what we're doing. This is just an illustration actually drawn by Omer Sharik, one of our fellows last year, but that mapping, why are we doing this, what are the lymph nodes, and being aware of it, and if necessary, while the patient's on the table and positioned and hyperextended into sleep, an intraoperative ultrasound. So we're selective users of that, and this is in the case usually almost exclusively for lateral neck disease and bulky neck disease. I like to identify where the highest lymph node is, so on that lateral neck dissection, I know if I need to be high level 2 or not. And so using that, and then there's the smirk, not a smile, incision positioning. And again, and usually it's the length of a tendon blade marked vertically on both sides, come in by half and make the incision shorter than that. This is what it looks like. And once we open, Jen, you use spring retractors. I use a little Gelpy and look for the midline strap muscles. I do not raise flaps. Find the straps, divide in the median raphe. We use coated Army Navies so that they don't get hot because the incisions are small and so that it doesn't burn the skin. And this is a depiction from the old Tony Edis book, which is the way that I learned, and this is the manual of endocrine surgery. And Tony was such a master surgeon, but more importantly, these original illustrations from Mayo really date back to the 60s and 70s and 80s. And this is the move of pulling the thyroid up and over. Those are Coker clamps. I often tell the residents, if it was good enough for Coker, the first surgeon to win the Nobel Prize, we're going to use it because he designed it to grab the thyroid tissue. So that move we describe as up and over. This is a picture of what I call the wrap, and now I'm going to show you, this is the contralateral side. This is a child that I did about 2 weeks ago, and so I actually took pictures for this talk, but after I finish one lobe and doing a total thyroidectomy, I'll wrap it with the Raytec to keep it clean and neat so that we leave the Gelpy and then we start side 2, and you see there the wrap. You see the Gelpy, and you see the Cokers moving the thyroid gland up and over. Something I learned from Norm Thompson when I spent time with him as a chief resident was Norm had no limit to the number of Cokers, and I don't know but you can continue to use as many as you need to pull that gland up and over. And you see, I identify the nerve early on in the case, and I identify it low, different than the Hoden technique. And you see the purple mark of the patient's sternum to the left. You see the coated Army Navies. You see the thyroid pulling it up and over. I use a right angle to find that nerve. And then bipolar, the tissue elevated off of it up into the point of insertion to identify early on that lateral branch of the recurrent, the one going along the esophagus. And then I take, this is it, showing again, tracking the nerve and finding it. I don't use a nerve monitor unless it's a selective use, a reoperation, bulky central neck disease, known contralateral nerve out, but not in a routine case. And this you see, I use the peanut to sweep the parathyroid tissue laterally, but staying on the medial side of it. I think identifying paras early on, even at the time before and at the time of identifying the nerve. And that's what I call the Farrah Fawcett sweep. It's with the peanut moving the hair, sweeping laterally to sweep all of that tissue over laterally. And you can see it there. Again, the rule for parathyroid protection begins early on, staying medial to the paras, sweeping everything on their lateral side laterally, never grabbing a para, and providing a little handle so that when you're moving the para or moving the nerve around it, you're never actually touching it. So you see those little parathyroid pearls, and those little rules, and you see that there. And again, that thyroid's being up and over, and you see the nerve. And then after I've identified the paras are swept down, the nerve is identified, then I come to take the inferior pole first, which I realize is not what Rich does and what everyone does, but I find everything medial to the recurrent laryngeal nerve is fair game. And if it's straightforward, I'm looking at the nerve and the paras lateral, I will use energy device at that point. along the whole inferior pole, and then I'll come and take the superior pole, pull it down and out, open that avascular plane, and use an energy device there too. And I don't routinely dissect up to identify the superior laryngeal nerve in that branch up there if I'm staying right on the thyroid capsule. And then the ligament of Berry and that organ of Zuckerkandl that Rich was talking about, again, showing it here, using a bipolar perpendicular to the nerve is where the second energy device comes in. And then I still use a sharp blade when necessary, when that ligament of Berry is really tight. And again, you can just see the coated army navies, you can see the parathyroid tissue there, you see the nerve. The lighting in the room, I think, is really important, something I learned from my own mentor, Dr. Van Heerden, and the Mayo Group. I actually operate with all the room lights off in the OR and just the OR lights, concentrating on the table. Always really important. Light straight from the front, straight from the back, and over the surgeon's side. I think the coloring is really important, of distinction of the nerve and that red fiber that goes through it, and just having the clarity of the sparkle on those parathyroid glands. So, Jen, like you say, you're OCD in certain parts of the case. I'm really OCD about the lighting being right and the positioning. I'm also pretty OCD about consistently tagging it. This is that child thyroidectomy, again, always tagging consistent, the same size. So pathology, there's never any disagreement whether it was right or left, whether the medullary, what side it was on, because I'm not sure about your ORs, but it's not uncommon. We have circulating room nurses that are in and out and changing, and all it takes is for someone to label that wrong. Understanding the gross dissection and looking at it on the back table before we actually send it to path. I always like to document. I'll have medical photography take a picture documentation in path, and putting it on a syringe just kind of shows what the positioning was in the trachea. And then old-fashioned, I close with Vicryl, interrupted in layers, bury the knots. I don't use Dermabond. I don't want the watertight seal. I actually want the ooze to happen if it's going to ever happen on that dressing, so that someone will call me earlier, not later. And that's the little coverlet, and we take those coverlets off the next morning. I'm going to leave with this one little quote from the original first governor of the state of Texas. One of the greatest pleasures and virtue a virtuous mind can receive in the world is the consciousness of having benefited others. So I hope this is helpful. It's been benefited me watching through the years all the different techniques and all the mentors. And I love the invitation and our different perceptions of what the assignment was. Thank you.
Thank you so much. Next, we have Dr. Herb Chen. He is the K. Fletcher Turner Endowed Chair of the Department of Surgery at the University of Alabama. He is also the Surgeon-in-Chief of the UAB Hospital and Health System, as well as the Senior Associate Dean for Academic Affairs. And so we're going to get a lovely rendition of his case.
Good afternoon, everyone. Could I have my slides? So another different interpretation about the assignment. So I actually, I'll apologize a little in advance for those of you who are eating or have eaten. So what I decided to do for this assignment is wear a GoPro on my head during the operation. I'm not going to subject you to the entire operation, but I just have some clips of the operation that I'll show from my GoPro, so I apologize for those of you who are prone to motion sickness. You may have a little bit of that. So can you find my slides?
You have Dr. Chen's slides, please.
Okay, can you go to the first one?
We have a back if you need it on there.
Oh, okay. Let me see. Okay, all right, so the first one. So I've had experience using, I think, all the instruments over time, and part of my decision to use them is driven by contracts that the hospital sets that dictate how much you have to use each instrument. So sometimes I end up using the instrument that they tell me I need to use. I do think any energy instrument is better than no, in contrast to Rich, because I think they make you much faster. All right, could you click on that first video there?
We do have to talk about this issue.
All right, so again, filmed with the GoPro on my head. We typically make a 4-centimeter incision, again, like Nancy, measuring from the cricoid, about a finger breadth down from the cricoid. I'd use local anesthesia, 2.5 cc's of 1/4% Marcaine that I put about a finger breadth above and a finger breadth below, so it doesn't show up in the incision when you're trying to bovie. You'll see me, see Peter Abraham or fellow making the incision here. Similar to Nancy, we'll bovie through the platysma, and I do not raise any flaps at all during the operation. And then I use the bovie to divide the straps vertically, but sometimes we'll use a cool seal to do that. So can you play this video? So after dividing the straps, my first moves is like similar to Rich, where I'll go to the upper lobe. And you can't see this very well, I know, but I'm using a Kittner, or a peanut like Nancy does, but I'm trying to create the space between the upper lobe and the thyroid cartilage, that bloodless plane. I do it bluntly with a sucker and the Kittner. And once I get established that space, I just put the peanut down and I use that to retract the upper lobe down. All right, can you play this video? So once the lobe is immobilized, I use a cool seal shown here. You can see the cool seal is very fast, and that's why I like it. And I double seal the vessels, and then divide the second seal closer to the thyroid. The cool seal seals in 0.7 seconds, and that's why I prefer it, because it's so fast. And if you'll notice when you're looking at the upper pole, another reason I like it is that when you're trying to see beyond it, to see the upper pole, on the first panel you can see, when looking in a hole, you can see past the shaft. It's much easier versus the harmonic and the ligature. The instrument itself gets in the way of your view when you're looking past, especially the upper pole. All right, can you play this video? Okay, so after taking the vessels to the upper lobe, I grab the upper lobe with an Alice clamp and pull down, and we're looking for the upper parathyroid, which can sometimes sneak up when you retract the upper lobe up, and that's Peter using the cool seal to seal the vessels that are in between the parathyroid and the thyroid. And my sucker's pointing to the parathyroid, the upper parathyroid right there. And we're just taking small seals next to it and then gently pushing it away as we lift up on the upper lobe. All right, can you play this video? And again, similar to Nancy, go back. Okay, and click on that video for me. Okay. So then after taking the upper lobe, you can see I put an Alice, and we call this birthing. We try to deliver the entire thyroid up and out. And using 2 Alices, putting one on the upper lobe, as shown on the right side of the screen, and one on the lower part of the lobe. And basically by rolling this over, that exposes the recurrent laryngeal nerve, which I always look for it just medial to the upper parathyroid. All right, can you play this video?
Okay, don't take that with
And
the
here
cool seal.
we're dissecting the recurrent nerve. I do not use a nerve monitor for any cases. We dissect the recurrent nerve now from lower to go up toward its incision. Typically use a combination of the right angle or the Schnitt tonsil forceps. And usually the fellow or resident presents the tissue sitting above the nerve like this, and then we take dividing the tissue like we're doing here, crossing on top of the nerve here with the cool seal. And the nice thing about the cool seal, you can use it for dissection too, because the tips are small. The tips rotate, so you can change the angle and stuff like that. And just to look at the tip, you can see the cool seal tip is small, but you can turn it, where the other instruments, the tips are fixed. And then this is a total thyroidectomy, so we're now on the left side. You can play the video, where sometimes we have the lower parathyroid can creep on up onto the thyroid.
That's the
And
parathyroid.
we use the
mobilizing down.
energy instrument to help
Off
both
the thyroid.
dissect it and push it away and divide the vessels in between that parathyroid here and the thyroid. And then after, it's important when we're talking the parathyroid, for a total thyroidectomy or completion, we do draw a PTH in the PACU. And based on the PTH levels, we'll determine how much, if they need any supplementation with calcium and or calcitriol, and it's dependent on the PTH level. But we have a protocol that really distinguishes between Graves' disease and non-Graves' disease, because we have found the needs for calcium and calcitriol higher with patients with Graves' disease, because we tend to operate on a significant number of patients who are not well controlled. And so this is our protocol. We've published it. Happy to give it, but it's pretty effective, and it's based on the PACU PTH. And then you can play this video. And sort of my last step, similar to Rich, to come up to the ligament of Berry, but we do this with the cool seal. Again, this is we're on the right side, coming up here. And I find if you mobilize the lower pole first and apply traction to it, and you can expose the ligament, and we have no problems taking the instrument right up close to the nerve and coming across. And that's because the cool seal, similar like ligature, there's hardly any thermal spread with it. And I think that I feel very comfortable using that, and sometimes Cauter very close. And then closure, I do use Surgicel. And then my closure is a 2-0 Vicryl for the straps, a 3-0 Vicryl for the platysma, a 5-0 monocryl, knotless. We pull no sutures through the entire, similar to Rich. There's not a single suture, tie pull during my cases. I use Dermabond, and then no dressing on top. Thanks very much.
Thank you so much. Can you bring back up my slides, starting with the cases, please? I just want to, since we have such a wonderful panel, I do want to ask and kind of go through some questions about some cases, because I think that your tips and tricks can help everybody in the audience, at least learners and less experienced people. This is the one I struggle with. I don't know about down here in the South, but the 52-year-old female with a BMI of 48, she has a papillary thyroid cancer, and she wants it, obviously is going to get a total thyroidectomy. So tell me how you position, how do you get so you can reach? I mean, I'm on multiple steps, I'm leaning, because even with the bed all the way down with the beach chair position, they're very high in the air. So I'm just interested, and then also for visualization, especially, I don't raise flaps as well, so there's, you must have tips and tricks for that. So if you could just help me out, how do you do it that makes it easier?
Well, I'm happy to start out. Few things. One is, I, like you, operate on many steps frequently. 3 steps side by side, foot pedal on my left foot, always ergonomically correct. I know we've got the importance of ergonomics in this audience, but always aim towards the head of the bed using the left foot pedal. I also will develop the space between the sternohyoid and sternothyroid with the back of a vascular to kind of pack, to make that retraction of pulling the thyroid up and over easier. And the third acknowledgement is ensuring that I've communicated well with anesthesia about muscle relaxation, particularly at the beginning of the, timing, and them knowing I don't want this patient paralyzed while we're, so much so that while we're waking up, it's going to delay waking up. But often just for that pull and that tug. And I also think in in this case, that positioning and an extra set of hands on the ipsilateral side to pull up and over would be things that I would think through, Mary Beth.
Yeah. Any other words of wisdom?
So we actually routinely position our patients completely supine, and something that one of our old residents brought from Hagi Mazadeh in Israel is instead of a traditional shoulder roll, we actually use an 500 milliliter arterial pressure bag. And we lie it vertically along the spine with the top of the bag aligned with the shoulders. And as you pump that bag up, it really brings it. Not only just allows that for that posterior extension, but it actually rolls the shoulders back. And you'll find, especially for patients with really like thick necks, that really opens up the neck space quite a bit. Having the patients completely supine also allows you not to just lower the bed completely, but also do a little Trendelenburg. And that will often bring the patient down to a level where even I can operate using one short step oftentimes. So.
That's great, yeah. So I actually use a bean bag. I put the patients on a bean bag, then when they're intubated, sit them up, roll it back so they get that extension. But I think everybody does it a little bit different, which is why we have this panel.
Let me just make one. I just want to make sure the credit is correct. So Huggy didn't develop that. So Rob Udelsman developed that, and that's how I learned from Rob to do it, and then Huggy was our first fellow to do it. So I want to give Rob credit for that.
Absolutely. The second case is a 45-year-old male with a multinodular goiter, compressive symptoms, including dysphagia. When you were doing your office ultrasound, you couldn't see the inferior aspect of the gland. So how do you proceed with that kind of case, and any tips and tricks for the, quote, substernal goiter?
So, I mean, do you have a CT scan? I mean, obviously, the key is to have a CT scan, and occasionally, certainly, probably have all had cases where you're sort of surprised that, it goes way down. You didn't realize that, but
yeah, we did a CT scan, and of course, it's above the aortic arch, so it's something you felt comfortable proceeding with.
I mean, I think there are all kinds of tricks. I'm sure everyone has their tricks to deliver a mediastinal goiter up into the neck. I think it's incredibly rare to need to do a sternotomy. I think everyone probably would agree with that. Do people use the spoon? Anyone here? You guys know the spoon.
Yeah.
The Belsey spoon.
Yeah.
That's like, after the third trick. I mean, obviously, the key to me is, number one, most of these goiters are kind of a little more most posterior, and you stay on the capsule, and you can deliver them up with your fingers, and maybe need a little instrument. I think the ones over the years, the ones that I've found are a little bit more challenging are the rare case where there's either because of a redo or something, there's no cervical component. If it's all down in the mediastinum, it's a little more difficult because you kind of don't have that tissue to kind of work with to follow it down. Also, the rare ones that are primarily anterior under the sternum, they're really huge. There's not a lot of space to deliver. I mean, I think you can do it through the neck, but a little more difficult. And then obviously at least in my experience, the occasional cancer. Usually these are benign goiters, but if it turns out that this big thing going down there is like, anaplastic cancer or some severe bad cancer, it could be a little more challenging. But anyway, I guess I'll stop there.
Two other points to mention are, I think, continuous retraction with the cokers, and imagining that we're putting the cokers laterally to pull up and over, and just to continue with that pressure, and not to remove the cokers once they're on. Right? It's not like put it on and then take it off, and then because there's going to be oozing in the thyroid. So but recognizing with those big ones, the more you go, you think you've got it all the way lateral. Your hand sweep and you're delivering, and wow, there's still it's only the top of the iceberg. So I think that's another important technical point. And I will, on occasion, remove the smaller side first to free up for mobilization, and to give room and to, to pull up and over. So I think being clever that way and thinking of alternatives, if it is big and socked in, how to mobilize that well.
Can I just add one point on that, because just to sort of agree with Nancy, whether it's, I mean, removing the smaller side is one way to think about it, but also a lot of times for really these big difficult ones, I'll definitely divide the isthmus early and dissect along the trachea into that plane, follow the anterior border of the trachea down, way down into the chest. It's safe, can't hurt anything there. And getting that medial dissection done makes it so much easier to kind of bring it up into the neck.
I think a couple of things to emphasize. I think the CT scan in these cases is so crucial because you can see the extent in the mediastinal extent, but it also, you have to really pay attention to the shape of that extension into the chest. Most of the time it's going to be sort of tubular in structure and nice and skinny. Those are the ones that you can pull up very easily. But there are others that narrow at the point of the thoracic inlet and then sort of blossom in the chest. Those are a lot more challenging to get out, and those we often will just notify thoracic to be on standby just in case. The other, we always talk about substernal extension on the CT, but the other aspect of the goiters, big goiters, that's really helpful is to see how much the posterior extension is. Sometimes you're looking at goiters that wrap around 360 degrees around the trachea and esophagus, and those are the ones that actually require much longer incision because of all that space, extra length to actually medially rotate the thyroid gland out. So I think CT is extremely important for these cases. And the other is your anesthesiologist, actually. So if I have a patient with a huge goiter that it's like super obvious, I actually request a specific anesthesiologist because I know he's not going to be freaked out. He's not going to be like pushing for fiber optic intubation of these patients. He can often safely intubate these patients with just direct laryngoscopy, and he's very calm and such. So that's a trick that I learned early, is that there are some anesthesiologists that you can work with that are very confident, can make your whole day a lot easier with these big cases than some that you don't work with very often.
Yeah, I think preparation's very important. So the next case is a 28-year-old female with a 6-centimeter PTC in her left lobe, and during the dissection around the posterior inferior pole, you note that the nerve is stuck to the back of the mass but not encased. And so please tell me how you kind of proceed with that case. It's the easy questions.
No, not easy. So I guess it depends on how stuck, right? And I mean, if you can carefully spend some time dissecting it off, you should do that. I think that sometimes if you have to leave a little bit of thyroid or tumor around it as opposed to sacrifice it, that's what I do too. And I usually do everything with like the Bovie or the instrument, but on the rare case, like Nancy showed with the scalpel, you can use that to sort of shave and get a closer margin to leave less on the nerve. But I would always do that first as opposed to taking the nerve. But if it's going right through the mass and stuff like that, usually the patient would have had some preoperative symptoms, and then in that case you had to have the conversation up front that you might have to take it. But if you don't have any symptoms and their pre-op laryngoscopy is fine, I would always try to save it by shaving the tumor off.
Anybody wouldn't shave and try to save?
I think the pre-op laryngoscopy is very important here, right? So as Herb said, hopefully the patient had some symptoms, you've got your preoperative laryngoscopy, and if you know that the nerve is out, I think your threshold for sacrificing it is much less. But if the nerve is intact preoperatively, you do everything that you can to save and preserve it.
Do you do laryngoscopy on all your cancer cases?
We do selective laryngoscopy, but for these large cancers, I think we do it much more consistently.
All right.
I think one of the other points too, in complement to what was said, in a tumor this size, selective laryngoscopy, but we actually use video stroboscopy instead of laryngoscopy, which is also recorded. And so it's also looking at it's looking at tone, it's looking at flutter, and it will give some information which will be helpful in that decision. But in a 28-year-old, certainly the intent of trying to save that, but not at the cost of pure, if it's already out for oncologic purposes.
Okay. And then the final case is a 57-year-old male with Graves' disease on methimazole for a few years, but he has waxing and waning symptoms, and he's really tired of this, so he is pretty well controlled, but wants his thyroid out. So can you guys run me through your thyroidectomy for Graves, and do you do Lugol's, don't do Lugol's? I find this is highly variable.
Well, I guess I'll start. The iodine, there's obviously literature out there that it can decrease vascularity and maybe blood loss a little bit on these cases, but I use it, I would say rarely, but in the Graves with really a huge goiter, I would definitely use iodine. Usually give them like 3 or 4 drops a couple times a day for like 10 days or so, and I'm not sure it makes a difference, but I use it, but not for, if it's not a huge goiter that I'm worried about, then with Graves, I don't generally use it. And I guess this has kind of been, was alluded to with Herb's slide about the calcium. I think these Graves patients are at higher risk for hypoparathyroidism. Those glands can be way up high and on the gland and at risk. So I'm just incredibly meticulous about staying, doing this capsular dissection that starts high on the gland, and even, maybe leaving a little bit of the thyroid capsule with the parathyroid as you're sweeping it down. And if there's any question about it, or if I think doing an auto transplant of at least one of the parathyroids, if you're questioning, is worth it to have that sort of in your back pocket. So I just think you have to be, particularly careful. And I think also the, risk of post-op hematoma is a little bit increased too. So just be very meticulous. Use a lot of the Bovie. I'm joking. It's the clips that are actually maybe the Bovie is for the pathologist.
Yeah, I think the question of iodine is always like pick your poison, right? It's either bloody and you have a nice spongy gland, or it's less bloody and you have a much more friable gland. But so we pick the friable gland. We routinely prescribe iodine for our patients. We do 2 drops 3 times a day for 7 days prior to the operation. And then I do think the potential for post-op hypocalcemia is really important with these patients. I think part of it, we find it a higher incidence in younger women, and so I think part of it is the high bone turnover that happens with the hyperthyroidism. So we actually preemptively replete on calcium and vitamin D up to the operation. And that has seemed to decrease our incidence of post-op sort of hungry bone in these patients. And then we do use morticial for these cases for hemostasis.
And how far in advance do you start your pre-calcium vitamin D?
At least 2 weeks, but it's more of a maintenance dose of calcium and vitamin D. So when I talk to my patients, I just tell them to start now, and then up until the operation, and then we have like a taper, high dose, and then taper on the post-op end. But even if I see the patients 2 weeks prior, almost everyone in New York is vitamin D deficient, so the extra vitamin D doesn't help, or it doesn't hurt.
Great.
I agree with Lugol's. We do use Lugol's, 3 to 4 drops 3 times a day, 10 days ahead. I also add a little propranolol, a little bit. If this is a vascular gland, vasculitis on ultrasound, bigger gland, just to I learned that from Arlo in and I don't know that we really do have data on the component, but if it decreases just a little bit of the pressure for a big anticipated bloody gland, I do a little propranolol in those days ahead. I agree with the points of the paras are particularly fragile in these patients. They're accustomed to a much more robust blood supply by sharing the blood supply with the thyroid. I would selectively, we do a selective calcium supplementation afterwards, but totally acknowledging that this patient is at high risk. And that would be a calcium PTH on the night of surgery at 5 p.m. and the next morning at 5 p.m. and looking for that trend and that drop, and but a very low threshold. But if I see that PTH increasing or that effectively, or the calcium going up, then I might not send them home on Synthroid and calcium. And I do think that ensuring that they understand from that propranolol that we wean that off, not just stopping the next day the Lugol, the propranolol, the methimazole, and stopping everything, just because sometimes those patients can get a little bit of a headache, and then we get a call, so just trying to preempt that. But agree with everything else said, and that's just the compliment.
So I've had the good fortune to work with two groups of outstanding grave surgeons. The first group at Wisconsin with Becky and Dave, we did a lot of studies together looking at what the best way, because we were operating on a lot of Graves patients, and we started a protocol of treating a week before with calcium. Sarah Altman wrote that paper up to show it reduces post-op hypocalcemia. And then when I moved to UAB, we, again, a ton of Graves disease, but this time a lot of uncontrolled Graves disease, which was difficult to control. And so we developed, again, a group protocol that we would have to operate on a significant number of patients who are uncontrolled. And we don't use Lugols based on a study that we had done at Wisconsin. But I think even if you can't get them under control with methimazole, there's great data to say that having them on some methimazole reduces the amount of vascularity in the gland. So. But I think about 33 or maybe more % of our patients are uncontrolled. Those are the patients that Andrea Gillis tends to see, not me or Vanessa or Sophie or Jess. But I do think it's important to discuss a sort of group management of these patients, because they can be more complex, both pre and post-operatively.
All right, well, I'd like to thank this illustrious all-star thyroidectomy panel, and I appreciate everybody's time, and I think that's it for us. In 15 minutes, we'll have the Orlo Clark lecture, so please, 15 minutes, make sure you're back here for 2 o'clock.